Good morning to all of you. I welcome you all on this NABI online tutorial series. I am Dr. Shamendra. I am Associate Professor in Department of Burns and Plastic Surgery at AIMS Raipur, Chhattisgarh. And I am glad that we have today Brigadier Dr. Devjyoti Sharma sir for today's discussion. He is presently working in Delhi Cant Army and Hospital Research and Referral, New Delhi. Sir has vast experience of more than 30 years in this field. He is recipient of Dr. C.R. Sundararajan Gold Medal Award in 2009 from MGR University, Tamil Nadu. Good morning, sir.
Morning.
Now for today's discussion, the general topic we have is safety and efficacy of waterjet debridement versus conventional debridement in treatment of extremely severe burns, a retrospective analysis. This study was done in Hui Medical University, China. It was published in the Burns Journal in June 2023. As we all know, burns remains one of the main causes of injury worldwide. And at Author Center, approximately 81% of the cases require surgical management. The basic surgical management we all know is debridement and split skin grafting. The tangential excision is usually done by Humby's knife, where tissue is removed. As per author, the tissue removed is often larger than necrotic tissue. And prevention of dermal tissue is important for not only wound healing, but also better scar of the wound. Sir, any idea about the burden of burns in our country?
If there are no clear-cut demographic and injury data available with us, but if you go with the world conferences, it is generally stated that India is the burn capital of world. So I presume we have large number of burn cases, which involves both domestic as well as industrial accidents. And most of us in government sector are dealing with burns patient in and out. And yes, the burden of burn injury is very, very high in our country.
Rightly said, sir. We don't have any central burn register system, and probably that is the main issue, that we don't have any data. Coming to other methods of debridement as described by the author, it can be enzymatic one and it can be a water jet debridement. Sir, any idea about enzymatic debridement in burn?
Enzymatic, we had a study in Army Hospital R&R way back in 2009-10, and it was published in Medical Journal of Armed Forces of India. Colonel Langa was the chief author, and our experience with papain urea was not very good. The number of patients went into sepsis earlier than expected by using this enzymatic agent, and that is why after that study we have not been using this in our setup.
Yes, sir. I think
The water jet debridement, I had a personal experience. We tried this in our command hospital at Chandigarh. Basically, it uses Smith and Nephew system of waterjet 2, where you have a console which is about a feet by feet, and it is powered by main electric source. It basically releases out a high stream of saline, and it causes a Venturi effect, remove the dead and necrotic tissue. The system itself is quite expensive. The console costs around 20 lakh rupees or so, and the handles, which comes in 3 different degrees, is basically made available between 45,000 to 60,000 rupees. It is a time-taking debridement, and as we discuss further, we will see what are the effects and advantages or disadvantages of this system.
yes, sir. It is popularized as Versajet 2 by Smith and Nephew, and basically it uses saline that is powered through a console for debridement, which and the saline acts as a knife. Regarding the benefits of using hydrostasis system, various authors have various opinions. Some say that it has reduced operative time, less operative blood loss, accelerated healing, less pain, and less adverse event. Whereas some has found no significant difference in healing of time, post-op infection, operative time, post-operative scar with the hydrosurgical debridement. So authors of this paper, they conducted a retrospective analysis in their patient, which they operated in 3 years from January 19 to August 22. Their inclusion criteria was patient between 18 to 80 years with total burn surface area more than 50%, and that those requiring the debridement with split skin grafting. Whereas exclusion criteria was patient with comorbidities that may hamper the wound healing, and the skin grafting was done using the Meek micrograft or conventional reticulated skin grafting. So coming to the flow chart of the study, total patient screened were 99, out of which 39 were excluded. Patient enrolled in the study were 60. Conventional group has 37 patient and hydrosurgical group were higher 23 patient. The data collected and analysis was done based on the demographic profile of the patient, length of surgery, wound healing time, hospital cost, RBC and plasma transfusions, post-operative inflammation, wound infection, and post-operative nutrition. So coming to the comparison group of demography of both the groups, here is the table that has been presented by the author. Sir, any take on this demographic data of the patient included in the study?
Uh, I have two observations. If you see the conventional debridement data, the TBSA range, the average is 80. And on hydrosurgical, that is the test group, it is 70. And if you further see, the deep partial thickness burn in conventional group was just 20, and all patient in test group had 23 patients. Whereas full thickness burn, there were 42 patients in conventional debridement group and only 26 in this is basically percentage wise 26% TBSA on hydrosurgical debridement. Now, if you look at it very carefully, patient with larger burn surface area had thicker burns wound and they were subjected to conventional debridement. So I feel there is a bias which creeps in here, wherein patient with higher grade of injury, both depth-wise and surface-wise, are subjected to conventional debridement, and patient with lesser surface and lesser thickness was subjected to hydrosurgical. So I feel there is some amount of bias which has crept in here. Now, if you see the debridement area, which is comparable in both the groups, 40% range in conventional and 37 in debridement. But most of the factors which authors have discussed further and which you are going to touch upon, we will discuss them as we reach there. And then I will try to elaborate what this bias has done to the result finally, which authors have commented upon.
Okay, sir. Coming to the results of the study, the authors found that the factors like operative duration, the hospitalization cost, and the plasma transfusion in both the groups were non-significant. Whereas the other factors like the duration of surgery, the recovery time, the number of RBC transfusions, change in hemoglobin concentration were found significantly better in the hydrosurgery group. So Sir, as per your observation, the result may be biased according to the demographic profile of the patients.
Yes. Now you see, once you are doing a larger area in a conventional debridement, obviously your operative duration will increase. When
Right.
you are subjecting your patient to a larger debridement, it will take more time. So that is my observation as far as that uh, uh, I earlier said. Again, the blood transfusion will be higher in conventional debridement because you are uh, going into deeper plane to debride. The scar is now being debrided at the level of subcutaneous tissue, maybe further deep. We don't know because authors have not commented on this. However, in discussion, they have said that at places they have, even in hydrosurgical group, people were subjected to conventional debridement because scars were very thick. That means wherever suited to the authors, they have used conventional debridement. However, they have included them in hydrosurgical debridement group. So that itself will skew the data in favor of hydrosurgical debridement. Now coming down to blood transfusion and hemoglobin requirement, like I said, more operative time, there will be more bleeding in conventional group, and hence blood requirement and hemoglobin concentration both will change in pre and post operative period.
Right, sir. I think selection of patient has changed the results in the study. Now,
Yes, that is
uh,
what my take is.
yes, sir. Now, comparing the cutting thickness of hydrocell system, it is quite small, 50 micrometer, that is 0.05 millimeters. Handle of the water knife is smaller, so each time it removes less necrotic tissue and blood loss is less. Whereas in conventional knife, the cut thickness is 0.25 millimeter to 1 millimeter, which easily cuts through the dermal capillary network, which lies between 0.3 to 3 millimeters. And therefore, in conventional group, the blood loss is more, which is estimated to be 77 milliliter per 1% TBSA of tangential excision. Uh,
So coming back to my observation, when you have a lesser thickness burn,
yes, sir.
obviously your hydrosurgical group will have lesser amount of blood loss.
Right, sir. This,
So that is how authors have skewed the data in their favor.
discussing the other points, they have found no significant difference in both the groups in fresh frozen plasma consumption, as fresh frozen plasma was given in both the groups pre and post operative for their maintenance of nutrition. Wound healing in hydrosurgery group was faster as compared to conventional group, as the dermal tissue removed by the hydrosurgery system was less, as author have cited in the study. Contrary to this study, KOYL et al. Found no significant difference between these two systems of debridement when the TBSA of burn is less than 25%. Sir, what can be the cause of this difference?
See, this is what I'm saying. The larger amount of necrotic tissue and deeper the burn injury, both the operative time, the blood loss, and recovery will take more. I mean to say, more time in recovery will be there. And in this study, the conventional group is the one which has had got larger surface area and deeper burn injuries. So obviously, patient in that group will take longer time to heal.
Yes, sir. In this study, the burn area was large, and probably authors have used conventional treatment as per their convenience.
Yes.
Uh, Seeing the other factors discussed in the study, there was no significant difference in the albumin level pre and post operative. The reason being they have been given albumin supplementation in both the groups adequately to maintain their nutrition. Another factor is pre-albumin. Pre-albumin is the indicator of malnutrition, and in this study, authors have stated that there is less loss of pre-albumin, which is significant in hydrosurgery group because the bleeding is less. So the hydrosurgery system is better than conventional group in terms of loss of nutritional components from the body during debridement.
Here I will come back to the same thing again. If you have a larger burn area, the nutrition of that patient will be a major factor. So if you have a larger and deeper burn area, those patients will require more nutrition. So the pre-albumin in and albumin in this hydrosurgery group will obviously be better than conventional group.
Right, sir. Now seeing the bacterial culture of wound surface before and after surgery in both the groups, it is not significant. But the inflammatory marker, which is being evaluated in the study procalcitonin, it is decreased significantly in the hydrosurgery system group as compared to conventional group. And what reason author has given that it does a very precise debridement and rapid debridement that has led to decrease in inflammatory marker rapidly in the hydrosurgery group. Sir, any take on this inflammatory marker?
My take from the beginning is the same. See, the patient with larger burn area and deeper wound will obviously are more susceptible to go into sepsis. So that factor also has to be taken into consideration.
Right. Another thing is that this marker is non-specific, so we cannot take out exactly.
Yes, in burns patient, this is a non-specific marker.
Yes, sir. Now coming to another point, which is very important, there is no significant difference in the hospitalization cost in both the groups due to disposable handle of the water jet being more expensive, and patient in this study included are having large burn area, which require multiple surgeries. Sir, what is the cost of handle being used in the hydrosurgery system? Any?
Like I said, it is anything between 45,000 to 60,000 rupees per handle. And the console itself, which is a one-time investment, varies between 18 to 20 lakh rupees. So the number of surgeries, if they are more handles you have to buy because these are disposables.
Okay. One disadvantage that author have said that during use of hydrosurgery system, there is production of polluting aerosols, which can pollute the surrounding environment. But exactly no details has been given that what effect it does to surgeon or what kind of aerosols it is producing. And another limitation, which already Dr. Sharma has pointed out, that in this study, when the larger burn surface patient were included, which were having thick HR, and the authors were not able to debride it with hydrosurgery system, then conventional debridement was used, and those data is absent from this study. Now coming to the concluding slide of this study. In this study, when larger surface area is used, the authors have concluded that the hydrosurgery system has significantly shorter operative time, less time for wound healing, less requirement of blood transfusion, less duration of hospital stay. But there is no difference in total hospitalization cost, bacterial load, pre and post surgery, total number of surgeries required, and number of plasma transfusion required. And disadvantage of hydrosurgery debridement is that it is less cost effective and production of polluting aerosols. Sir, any take home message regarding using this system in our perspective, Indian perspective in our hospitals?
See, I would say most of these burns patient in our setup are treated at government hospitals. Now, we are already resource crunched, and to have this system to operate, it is quite a costly affair, number one. Number two, when you have a limited operating time and your burn wound is deep, say it is full thickness burn, and it is my personal experience also that as a surgeon you get impatient with hydrosurgical system and you tend to go in for conventional debridement to save your patient from hypothermia and to close the wound as early as possible on the table. So hydrosurgery, I would say, will be much more effective in difficult areas because the cutting edge is small. So say facial burns or genitals or perineum where you have to excise a smaller area. And if it is say partial thickness burn, that time hydrosurgery could be much more effective than our conventional debridement. Even on hand and fingers, I would prefer to have a hydrosurgery done than to go in for a conventional debridement. But as the wound become thicker, deeper, and the surface area become larger, I still feel for our setup, conventional debridement is the answer.
Uh, Thank you, sir. I think we have a very short and very good discussion, which was very thoughtful for the listeners. And in a very short period of time, we have come to get a detailed knowledge of advantages and disadvantages of the hydrocycle system from you, sir. So, coming to end of this tutorial, with this take-home message, we thank to Dr. Dev Sharma sir for joining us today, and I am thankful to the all listeners for patiently listening to us. Thank you, sir.
Thank you.